Adult Cancer Pain Management, Pharmacist's Training Course, Comprehensive Training on Pain Management Strategies and Guidelines. The multidisciplinary team commonly consists of primary care providers, anesthesiologists, psychologists, nurses, and physical and occupational therapists, with additional involvement from surgeons, neurologists, internists, physiatrists, psychiatrists, social workers, dietitians, and pharmacists. Objectives: to equip pharmacists with the essential knowledge and skills needed to effectively manage cancer pain. Ensure pharmacists understand the pharmacology, indications, dosing, and side effects of the new narcotics. Empower pharmacists to counsel patients effectively and ensure safe use. Educate patients on the proper use, risks, and benefits of the medication to enhance adherence and safety. To establish a standardized approach for pharmacists in cancer pain management, enhancing patient comfort and palliative care outcomes. Our training sessions will focus on 5 main topics. It will be represented in 5 to 7 lectures. Let's take a look on prevalence of cancer pain and severity. Cancer pain remains a significant issue negatively impacting the quality of life for patients. And, based on systematic reviews from 2 periods, in 2005 to 2014, overall pain prevalence, 55.0% during anti-cancer treatment. And they record that moderate to severe pain was 38.0%. In 2014 to 2021, overall pain prevalence, 44.5%. During anti-cancer treatment, and moderate to severe pain was 30.6%. So, further research and clinical advancements should aim to address these gaps in pain management to enhance patient quality of life. Cancer pain prevalence. If we are looking at the prevalence first according to origin of cancer pain, most cancer pain is tumor-related, about 50 to 60%, caused by tumor invasion or compression. Therapy-induced pain, from surgery, chemotherapy, or radiotherapy, accounts for approximately 20 to 25%, while pain unrelated to cancer represents a smaller portion, approximately 3 to 10%. Pain in advanced, terminal cancer. Around 55% of patients with advanced or terminal cancer experience pain. Breakthrough pain. Among patients who already have background cancer pain, approximately 70% experience breakthrough pain, which is sudden, severe, and short-lasting despite regular analgesics. Overall cancer pain burden. 55% of patients receiving cancer treatment report pain, and this increases to approximately 66% in patients with advanced metastatic or terminal cancer, highlighting progression-related severity. Cancer pain prevalence by cancer type. Pain prevalence varies by cancer type, ranging roughly from 50% to 70%, with head and neck cancers showing the highest prevalence, followed by gastrointestinal, lung, breast, urogenital, and gynecological cancers. Several organizations focus on pain management, aiming to improve patient outcomes, enhance professional knowledge, and promote better treatments. Key organizations include International Association for the Study of Pain, IASP, an organization dedicated to advancing the understanding, prevention, and treatment of pain worldwide. World Health Organization, WHO. The WHO plays a role in promoting the use of effective pain management practices globally, including advocating for the availability of palliative care. The word pain. The IASP definition of pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. It was recommended by the Subcommittee on Taxonomy and adopted by the IASP Council in 1979. In 2020, pain definition had been updated to a new one. It was an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So, if we look at the word resembling, what are other words for resembling? The answer is like, similar, analog, parallel, matching, corresponding. The nervous system. As we know, the nervous system is classified in 2 main parts. The central nervous system, including brain, brainstem, spinal cord. And here, nerve axons consist of slender projections and carry significantly short nerve impulse. The CNS major function is to organize and analyze the information obtained from sensory organs. On the other hand, the peripheral nervous system, it is included First, the autonomic NS, which includes sympathetic and parasympathetic NS, and secondly, the somatic NS. The PNS composed of long nerve fibers with a length U to 1 meter. The PNS major function is to transmit sensory information to the central nervous system and pass out motor impulses to the sensory organs. Here, we can see the physiology of pain. Presence of any painful stimuli is transferred to the sensory nerve ending, which is called nociceptors, then giving an impulse to the spinal cord, reaching the brainstem, finally to the brain, ending in feeling of what we called pain. But the question is, why cancer is more painful compared to normal tissue injury? Actually, the cancer cell plus macrophages plus inflammation cells can produce high level of COX-2 enzyme, which leads to high level of prostaglandins. Another action can occur also. Cancer cells induced acidosis due to that inflammatory cells invade neoplastic tissue and release H+, and massive apoptosis also contribute release H+, so all that increase acidosis, so inflammation occur with higher pain sensation. Do you know what is the difference between central sensitization and peripheral sensitization? In central sensitization, the nervous system amplifies sensory input across many organ systems. It occurs in neoplastic changes. Example, phantom limb pain. But in the peripheral sensitization, a reduction in the threshold and/or increase the magnitude of responsiveness at the peripheral ends of sensory nerve fiber leads to exaggeration and extension of pain response. Example, osteoarthritis. This slide can also figure out the differences between peripheral and central sensitization. Pain classifications. There are many ways to classify pain according to etiology, pathophysiology, location of pain syndromes, temporal classification, and finally according to severity. You can also see another method for pain classification. According to pathophysiology, duration, mechanism, cause. Here, another method which is more famous to classify types of pain. INTA, nociceptive, which includes somatic or visceral, neuropathic, physiologic pain. You can see here many examples on somatic pain, visceral pain, neuropathic pain. Temporal classification. Classify cancer pain as acute, chronic, and breakthrough pain. Cancer therapies can cause several pain syndromes. Post-chemotherapy. We can find myalgia, arthralgia, chemotherapy-induced neuropathy, treatment-related muscle, joint pain, oral mucositis pain, hand-foot syndrome. Also, as an example to post-surgical pain, you can find post-mastectomy pain. Radiation therapy also can lead to mucositis, skin inflammation, and chronic fibrosis pain. Total pain. Total pain is a holistic concept describing the full burden of suffering experienced by patients, especially those with cancer, where pain is not only physical but also includes emotional distress, social pressures, and spiritual or existential concerns. Together these dimensions interact and amplify each other, so effective management must address the whole person, not just the physical symptoms. Main goals of cancer pain management. The primary goals are to achieve effective and sustained pain relief, improve the patient's overall quality of life, maintain daily function and independence, prevent pain from escalating through proactive treatment, minimize medication side effects, and address the full concept of total pain, including physical, emotional, social, and spiritual dimensions, to ensure truly holistic care. Barriers to effective cancer pain management. 1. Institution-related barriers. Limited availability of diagnostic tools and advanced treatment modalities. Long waiting times and inefficient referral systems. Shortage of oncology centers, beds, or radiotherapy machines. High treatment costs and inadequate insurance coverage. Weak infrastructure for palliative care and follow-up services. Poor coordination between departments and fragmented care pathways. 2. Healthcare professional-related barriers. Shortage of trained oncologists, oncology nurses, and pharmacists. Limited continuous medical education or exposure to updated guidelines. Delayed diagnosis due to misinterpretation of early symptoms. Poor communication with patients regarding prognosis and treatment options. Inadequate pain assessment and management. Burnout or high workload affecting decision-making and patient support. 3. Patient-related barriers. Late presentation due to low awareness or cancer stigma. Fear, denial, or misconceptions about cancer and its treatment. Poor adherence to treatment from side effects or social, financial constraints. Preference for alternative therapies delaying medical care. Limited social support or transportation difficulties. Comorbidities affecting tolerance to therapy. Cancer pain assessment. It is essential to effectively manage pain and improve the quality of life for cancer patients. It involves understanding the intensity, location, quality, and impact of pain on a patient's daily life. Pain assessment. Let's summarize the most important points. Universal screening. It means screen all patients for pain at each encounter. Use validated tools like numerical rating scales or behavioral observations for nonverbal patients. Comprehensive pain assessment. Be aware to evaluate the cause of pain, its intensity, trajectory, and psychosocial impact. Assess for aggravating, alleviating factors, breakthrough pain, and response to prior therapies. And don't underestimate these special considerations. Incorporate cultural and linguistic factors in assessments. For nonverbal patients, rely on behavioral cues, caregiver input, and response to interventions. Comprehensive pain assessment. The acronym PAINed. P. Place. Where is the pain? Does it radiate? A. Activators. What triggers or worsens it? Movements, food, stress? I. Intensity. How severe is the pain? You can use 0 to 10 scale, VAS scale. N. Nullifier. What relieves it? Medications, rest, heat, cold? E. Effect. How does it affect daily life, mood, sleep, appetite? D. Description. Quality of pain. Burning, stabbing, throbbing, aching, numbness? The NCCN Guidelines for Adult Cancer Pain, version 3.2024, provide evidence-based recommendations for assessing and managing pain in adult cancer patients. Pain can arise from the tumor itself, treatment, surgery, chemotherapy, radiotherapy, or other comorbidities. Proper management is crucial as pain significantly affects quality of life, functional status, and psychological well-being. Importance of using NCCN guidelines. They provide standardized, evidence-based guidance to ensure safe and effective pain management. Facilitate multidisciplinary care, helping clinicians, pharmacists, and other healthcare providers coordinate treatment. Support clinical decision-making in complex cases and prevent undertreatment or overtreatment. Help maintain consistency in care across institutions and improve patient outcomes. Serve as a reliable reference for updating clinical protocols and educating healthcare professionals. Pain assessment scales. They are tools used to quantify a patient's pain intensity, quality, and impact on function, helping guide effective pain management. They are essential because pain is subjective, and scales provide a structured way to communicate and track it. Pain assessment scales are used to evaluate, measure, and monitor pain for effective management and communication. Choose scale based on patient's age, cognition, and communication ability. Regular assessment is crucial for monitoring response to treatment. Combining patient self-report with clinical observation improves accuracy. Here are common types. 1. Numeric rating scale, NRS. Patient rates pain from 0, no pain, to 10, worst pain imaginable. Simple and widely used. 2. Visual analog scale, VAS. A 10 cm line where the patient marks pain level. Provides continuous measurement of pain intensity. 3. Verbal rating scale, VRS. Patient chooses descriptive words. No pain, mild, moderate, severe. Easy for patients who struggle with numbers. 4. Faces pain scale. Uses facial expressions to represent pain intensity. Useful in children, elderly, or cognitively impaired patients. 5. Multidimensional scales. Examples: McGill Pain Questionnaire, Brief Pain Inventory. Assess pain quality, intensity, and impact on daily life. The next slides cover key pain scales and their applications. McGill Pain Questionnaire, MPQ. A comprehensive tool that assesses the sensory, affective, and evaluative dimensions of pain. It uses descriptors like throbbing, shooting, and burning. Useful for complex, multidimensional pain, somatic, neuropathic. Functional assessment of cancer therapy pain. FACT-P. Measures pain interference with physical and emotional well-being, including how pain affects the patient's ability to function. Subjective pain assessment is based on the patient's self-report of their pain experience. This is the most reliable method in patients who can communicate effectively. A. Pain intensity scales. Numerical rating scale, NRS. Patients rate their pain from 0, no pain, to 10, worst possible pain. Common in clinical settings due to its simplicity and ease of use. Visual Analog Scale, VAS, a 10 cm line where the patient marks their pain intensity from 0, no pain, to 10, worst pain. Useful in clinical settings but less commonly used than the NRS. Verbal Rating Scale, VRS, patients select a word that best describes their pain, e.g., mild, moderate, severe. Often used in non-English speaking populations or those with limited literacy. B. Pain quality and characteristics. Descriptors. Patients are asked to describe their pain using adjectives: dull, sharp, burning, aching. This helps to differentiate between nociceptive and neuropathic pain. C. Pain location. Body diagram. Patients are asked to mark the areas of pain on a body diagram. Useful for identifying widespread pain. Bone metastasis, muscle pain. D. Impact of pain on function. Brief Pain Inventory, BPI. This tool measures both pain severity and the degree to which pain interferes with daily activities, walking, sleeping, working. Remember that, in order to make a comprehensive pain assessment, ensure that you have detailed history, current pain management plan and the patient's response to prior pain therapies. Important psychosocial factors, patient distress, family and other support, psychiatric history. Diagnose the etiology and pathophysiology of the pain, somatic, visceral, or neuropathic. Basic principles of pain management. Keep this in mind as you move forward. 80% of cancer pain controlled with simple means. 20% requires multidimensional approach, reassessment of pain syndrome and use of second-line agents and/or non-pharmacologic interventions. Always need to address and/or treat the cause of the pain, like, treat the cancer. Maximize pain relief and minimize side effects. Guidelines for pain management. During addressing the critical challenge of cancer pain management, we are guided by leading authorities like the WHO, the American Pain Society, and the NCCN. Our approach is strategic and multimodal. We attack pain on 3 fronts. First, by modifying its source through treatments like surgery, radiation, or chemotherapy. Second, by altering the brain's perception of pain using tailored analgesics and psychological support. And third, by blocking pain signals themselves with advanced interventional techniques like nerve blocks or targeted drug delivery. This comprehensive framework allows us to develop personalized pain management plans, ensuring we not only treat the disease but also uphold our patients' dignity and quality of life throughout their journey. Cancer pain management interventions. Cancer pain is a complex, multifaceted condition. The therapeutic arsenal is broadly categorized into 3 integrated domains, allowing for a personalized, multimodal regimen. 1. Pharmacological management. This first-line approach utilizes systemic medications targeting specific pain pathways. Non-opioid analgesics. They are foundational for mild to moderate somatic pain. Opioid analgesics. The cornerstone for moderate to severe pain. Antidepressants. First line for neuropathic pain. Anti-epileptic drugs, AEDs, first line for neuropathic and radicular pain. Other adjuvants, corticosteroids, for inflammation and edema, muscle relaxants, and bisphosphonates, for bone pain, are used for specific indications. 2. Interventional and procedural techniques. These are employed when systemic pharmacotherapy is insufficient, intolerable, or causes dose-limiting side effects. 3. Non-pharmacological and integrative therapies. These address the biopsychosocial model of pain, targeting the cognitive, affective, and functional dimensions. They are synergistic with biomedical treatments. The selection and sequencing of therapies from these 3 domains are dictated by a comprehensive assessment of pain etiology and the risk-benefit profile of each intervention. The goal is to achieve optimal analgesia while minimizing adverse effects and maximizing the patient's quality of life and functional autonomy. The WHO Analgesic Ladder. A simple stepwise approach for cancer pain management. The ladder was introduced by the World Health Organization in 1986 to reduce undertreated cancer pain worldwide and to standardize safe, effective pain relief. The ladder was a practical 3-step framework first published to guide pain treatment in people with cancer. Over time, clinicians and guideline bodies updated and expanded the idea, including a proposed 4th step for interventional procedures when drugs alone are not enough. The ladder gives a clear, easy-to-follow sequence so clinicians treat pain according to intensity. It emphasizes oral, regular dosing and combining non-opioids, opioids and adjuvants to maximize effect. It helped reduce stigma and underuse of effective opioids for cancer pain around the world. The latter recommends starting with non-opioid drugs for mild pain, adding or switching to weak opioids for moderate pain, and moving to strong opioids for severe pain, with adjuvant medicines and non-drug measures at every step. So, how to use it? Assess the patient's pain intensity and causes, then start treatment at the step matching the pain level. For mild pain, use paracetamol or NSAIDs plus or minus adjuvants. For moderate pain, add or switch to a weak opioid plus or minus non-opioid. For severe pain, use a strong opioid plus or minus non-opioid and adjuvants. Reassess frequently and titrate dose until effective analgesia or intolerable side effects. If pain is uncontrolled despite these measures, consider specialist options such as nerve blocks or spinal techniques, the so-called fourth step. If you look at these diagrams, in step 1, non-opioid analgesics such as paracetamol or NSAIDs, consider adjuvants, antidepressants, anticonvulsants, for specific pain types. Step 2. Weak opioids, historically codeine, tramadol, for mild to moderate pain, usually combined with non-opioid drugs. Step 3. Strong opioids, morphine, oxycodone, fentanyl, for moderate to severe pain. Use the lowest effective dose and manage side effects. Step 4. Interventional treatments, nerve blocks, epidural or intrathecal therapy, or other procedures for refractory or very severe pain. This edition appears in modified ladders and guideline updates. The horizontal rungs map to pain intensity. Mild followed by mild moderate, then moderate severe reaching severe pain. Move up when pain is not controlled. The upward arrows represent increasing analgesic potency and need for specialist input at the top. The lower box, arrow showing short-acting then long-acting, indicates using long-acting opioids for persistent baseline pain and short-acting or rapid-onset opioids for breakthrough pain episode. Here is another important point, connecting this idea with the previous one. Reverse pain ladder. The reverse pain ladder is a step-down approach used when pain is already severe and then gradually improves with treatment and healing. It starts from the strongest level of analgesia and steps down as the patient's pain decreases. It is mainly used in acute pain, postoperative pain, trauma, or any condition where pain naturally resolves over time and excessive opioid use must be avoided. This model was developed to solve the problem of continuing strong opioids longer than needed. When pain improves quickly, stepping down prevents unnecessary side effects, dependence, and opioid-related harm while still maintaining good control of symptoms. Step 4. Used for pain rated 8 to 10 out of 10. Includes PCA, patient-controlled analgesia, epidurals, long-acting local anesthetic infusions, or specialist techniques. Given together with Step 1 treatments and adjuvants. No additional opioid should be added unless approved by the pain or anesthesia team. Step 3. When pain improves but still significant, use regular strong opioids, sometimes combined with NSAIDs and regular Step 1 medications. NSAIDs are used with caution, especially in elderly patients or those with renal risk. Step 2. For moderate pain that continues to improve, switch to weak opioids such as tramadol or codeine plus NSAIDs plus Step 1. This stage prevents early over-reliance on strong opioids. Step 1. Regular paracetamol and NSAIDs if not contraindicated. Often sufficient once healing progresses and pain is mild and not interfering with activity. Adjuvants can be added at any stage. Examples include gabapentinoids, Entonox, antidepressants, or non-pharmacological measures like physiotherapy, ice, relaxation, and breathing techniques. Also, let's take a closer look at the functional assessment box. Here, severe pain equals 3, which means interferes with both rest and activity. Moderate pain equals 2, which means interferes with some activities but patient still functioning. Mild pain equals 1, which means resent but does not interfere with activity. None equals 0, which means pain-free. This functional score helps decide when to step down in the ladder. It shows the core principle of the reverse ladder. Reduce analgesic intensity as pain resolves with healing and time. Finally, to illustrate this point, what is the benefit and when to use the reverse pain ladder? The answer is benefits. Prevents prolonged opioid exposure. Matches analgesia to the natural downward trend of acute pain. Reduces side effects, sedation, constipation, and long-term dependence risk. Encourages early return to function and mobility. Ensures safe, structured prescribing. Uses. Postoperative pain. Acute trauma, acute musculoskeletal injuries, severe inflammatory conditions expected to improve rapidly. Any situation where pain decreases predictably after treatment. Let's now shift our focus to the administration of analgesic medicine for cancer patients and reinforces the main principles. Clock alarm clock, right time by clock, given on a regular basis by the clock rather than on demand. Explanation. This emphasizes the by the clock principle, which is critical for preventing the pain from escalating. Regular, scheduled dosing ensures continuous pain relief. Mouth, lips, mouth, oral administration is preferred. Explanation. This confirms the by the mouth principle. The oral route is generally the simplest, most convenient, and least expensive method for administering analgesics, especially for long-term care. Patient standing, individual basis. The dose should be determined on an individual basis. Explanation. Pain management must be personalized. The right dose varies greatly among patients due to differences in pain severity, drug metabolism, and pain type. Healthcare providers must continually assess and adjust the dose until the patient reports satisfactory relief. How effective is it? The systematic application of these principles is profoundly beneficial and effective. High success rate. Studies have consistently shown that the WHO analgesic ladder, when properly implemented, can achieve adequate pain control in 70% to 90% of cancer patients. Improved quality of life, QOL. Effective pain relief allows patients to function better, sleep more soundly, and maintain better psychological and social well-being, which is the definition of a better QOL. Cost-effective. Favoring the oral route, by the mouth, makes treatment more accessible and less expensive compared to relying on intravenous or specialized routes. Simplified treatment. The systematic, ladder, approach provides a simple, structured framework that is easy to teach and implement, even in resource-limited settings. So, to illustrate, give right drug by the ladder using the right doses at the right time. Finally, while we are moving forward, we have to keep in mind that the National Comprehensive Cancer Network, NCCN, clinical practice guidelines for adult cancer pain, specifically focusing on ongoing care and monitoring. The guidelines emphasize a holistic approach, starting with continuous follow-up to reassess pain control, minimize adverse effects, and ensure smooth care transitions. The goals of treatment are centered on optimizing analgesia while managing side effects like constipation and delirium, alongside monitoring for aberrant behaviors. Furthermore, the document highlights the necessity of comprehensive psychosocial and supportive care, which involves providing emotional support and training patients in coping skills such as relaxation and cognitive restructuring. Key considerations also include patient education on safe opioid handling and addressing equity in care by tackling financial, cultural, and systemic barriers to ensure all patients receive culturally sensitive and linguistically appropriate pain management. The remaining slides contain diagrams and schematics that are not explained here, but they are available in the NCCN guidelines for reference and further details on treatment approaches.